I'm like really rich and everybody loves me and I'm like really attractive.
Treatments that we've been trained to do are still harmful.
What do trans people look like, quote unquote?
Welcome to OCD Whisper podcast. Today with me, I have two incredible guests. Dr. Lauren Wadsworth, who is a board-certified clinical psychologist, founder and director of Genesee Valley Psychology, clinical senior instructor in psychiatry at the University of Rochester Medical Center, and diversity, equity, and inclusion senior advisor at McLean Hospital, Harvard Medical School. She is also a co-founder of Twin Star Intersectional Diversity Trainers and author of Did That Just Happen? Beyond Diversity, Creating Sustainable and Inclusive Organizations, a groundbreaking book on fostering diversity and inclusion in the workplace. We also have Dr. Caitlin Pinciotti. Welcome back to the show. She is a licensed clinical psychologist and assistant professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. Dr. Pinciotti has an expertise in the assessment, conceptualization, and treatment of OCD, trauma, and PTSD, and a secondary interest in identifying and addressing mental health inequities in gender and sexual minorities. She has presented on these topics at regional, national, and international conferences and has published these topics in over 34 peer-reviewed scientific articles. Welcome to the show.
Thanks for having us.
Absolutely. I am so glad that you said yes. So for anybody that's listening, what really happened is I basically stalked Dr. Pinciotti on Twitter. I found this tweet that she posted and I thought, what a cool topic. And I would love to actually discuss this. And then Dr. Pinciotti was kind enough to say, I have somebody else that should jump on here. So here we all are.
Thank you for having us. And I will defer to Dr. Pinciotti on the person that really started this, this wave in the field. And I'm just excited to be here alongside her.
Amazing. So what we're talking about today is justice-based treatment for OCD. And, it caught my attention because I was wondering, well, what does it really mean, right? It's a lot of words together. So I thought, let's jump on and talk about this. So that's my first question for both of you is, what is justice-based OCD treatment?
I can start and then Lauren, you can hop in too. But we use that term to describe a treatment approach that considers the client, the provider, and society as a whole. So, it was born out of kind of a recognition that in some cases we were sort of prioritizing OCD symptom reduction at the cost of people who belong to marginalized or minoritized communities, some of whom sometimes are the treatment provider or maybe the client's peers. So the idea is let's consider everyone and be respectful of everyone in our treatment approach.
Yeah, and just to name that, or just to add that the treatments that we've been trained to do, that I was trained to do in leading settings in the country, are using approaches that are still harmful. So some of the examples we give might seem ludicrous or unbelievable, and just want to say that they are being trained and reinforced in a lot of places. So our hope is that we can keep spreading this message. We really appreciate this platform because this is oftentimes an injustice that's currently happening and being actively trained.
Okay, well, since both of you kind of mentioned that, I would love to hear, I think anybody listening right now would love to hear some examples, right? So we can get a little concrete about this.
Sure.
Whoever would like to jump in.
Examples. Sure, I can start with some examples related to race and socioeconomic status, and Dr. Pinciotti, maybe you can add some sexual orientation and gender examples. So sure. Some examples that I was trained to do would be if someone has OCD related to fears that they might be racist, quote unquote, or do something racist, they might be instructed to do an ERP where they are writing down racial slurs over and over and over for 30 minutes or an hour, maybe even saying those slurs out loud over and over and over, either on their own in private or on a residential unit or setting where there are other people in the milieu as well. An example related to socioeconomic status might be going to a homeless shelter or a houseless shelter and just standing near people that might be without a home or low SES, and having that fear, triggering that fear of contagion or being becoming contaminated by someone that is struggling financially.
Yeah, and in terms of gender and sexual orientation, a lot of them that we were trained in, that we're starting to rethink, are, capitalizing on kind of stereotypes about what it means to be LGBTQ plus. So if somebody had fears that, or a doubt that they might be transgender, well, what do trans people look like, quote unquote, and then go out and dress, overly masculine or overly feminine, maybe kind of mimic, like if you had a concern about being gay, like what are some of the, again, these are all stereotypes, like mannerisms that gay people might have, and then go and have a conversation with someone where you're kind of mimicking gay people. So really kind of these exposures that sort of capitalize on these incorrect and harmful stereotypes. And that also, in some cases might carry an actual risk to the person if they're behaving a certain way in public and they encounter someone who's really prejudiced and has a strong negative reaction to that.
These are, I think, excellent examples. Yeah, I think this helps anybody listening to wrap their head around. And I'm sure for, anybody who has OCD and has dealt with any of these subtypes specifically that you've mentioned, I can imagine, and I know as a provider, like, yeah, those are the ways you're trained, right? And the fact is, yeah, you want to kind of step back and go, wait a second, right? Like, these are also like fellow human beings. And so, with that question, I think obviously the next question that anybody listening would probably have is, well, what would be other ways? What would you suggest? What would you recommend in terms of then how could you change the exposures, right? Like maybe somebody's thinking acceptance commitment therapy, values-based, but that's just kind of one idea that comes to mind. But what would you suggest? What are some ideas?
I think that definitely like using ACT and components like that can be really helpful. We can also take a justice-based approach to ERP, so we can still be doing exposure therapy, but just in a way that isn't, tokenizing marginalized people, isn't using them as props, isn't kind of like reinforcing harmful stereotypes. And so one thing that we like to talk about is kind of when you're generating these exposure ideas, like reflecting on some questions about what am I really getting at here? Is there a different way that I can get at this fear that isn't, adding harm to this community? I think the biggest question that I encourage people to ask themselves is, would you feel comfortable doing this exposure in front of someone who holds that identity? So for example, if you're telling a client, go ahead and write the N-word on this whiteboard and we'll just make sure that no BIPOC people come into the room, that's when you really need to sort of question, like, well, wait a minute, if we're having to hide these exposures from some people, we should probably listen to that gut instinct. And so there are ways that we can address really like the underlying fear without contributing to this minority stress and discrimination. So the person probably isn't on the surface just simply afraid of being gay and that's it, right? A lot of times it's more so just a doubt or feeling like, how am I supposed to move forward with my life if I don't know who I truly am? And maybe they don't really care either way. If I'm this or I'm that, that's okay with me. I just need to figure it out. So we can do exposures to that kind of uncertainty and maybe whatever core fear is underneath that. So maybe the core fear is like, I've been living an inauthentic life. I've been lying to my loved ones or to myself. Okay, great. Let's do some exposures of maybe other times when you were inauthentic or dishonest with people, because I'm guessing that those are probably also triggering for you, since that's what's underlying all of this. We can also use, and I can let Lauren expand on this or other things too, but principles of like psychoeducation. So a lot of times, because people's OCD so distorts their beliefs and perspectives about groups of people, they might just misunderstand aspects of certain identities or communities. So we can use psychoeducation and have people really educate themselves on different aspects of a community, which would both, address perhaps misinformation that they have, but also probably be a pretty potent exposure for them as well.
Yeah, that piece of engaging in psychoeducation or learning about other communities could also target avoidance. If someone is avoiding being around people that they perceive as gay or queer, they might be going to a pride parade might be at the top of their hierarchy, right? So going to a pride parade, cheering along, could be a way to do an exposure and a values-based activity if deep down in your heart you would want to support and uplift marginalized communities. Another example of getting at that underlying core fear, we can think about, again, that fear of being perceived as racist. If we get under that, it might be more about being seen as a bad person or being a bad person deep down. But if we really do a downward arrow or use some Socratic questioning around that specific fear of saying a racial slur, we can help the patient understand or client understand that saying a word doesn't make you racist or not a racist or a good person or a bad person, that it's really more of a system of racism that we're all living in and we are all a part of, especially if we are white like me. So understanding the ways in which it's much more complicated than the words that come out of your mouth literally in a social interaction. And we can target the uncertainty by, instead of writing down the racial slurs, having a conversation with someone about maybe the topic of race and risking saying a word that could be perceived as negative or harmful. We can engage in expanding our relationships to people who have different racial identities than ourselves to, again, risk making a mistake using a valued action of connecting and building a relationship.
I love that. These are all such great examples. And I love that reframe and that slowing down and really checking in truly like what's underneath this, right? And you both really spoke to that. A lot of times for folks with OCD, it's more this notion of somehow maybe I'm a bad person or I'm going to do something terrible or I'm going to get something and be stuck with it or pass it on. And so exactly expanding kind of the definition, how else can we address those fears, right? How else can we get at that? I'd love to ask you, if we're thinking about things for providers, right? For clinicians who specialize in OCD, what do you think could be some things that they should be aware of in terms of when working with these themes, or what are ways that they can kind of help themselves to retrain, reframe, and kind of start to adjust this?
Dr. Wadsworth, do you want to take this one first, or?
Yeah, so I want to come back to something Dr. Pinciotti said, which was that gut check of would I do this with anyone in the room? Because for me, that's the thing that helps me make those decisions the most in the moment. It's a quick question. It's something that we can answer right away. If we have a gut feeling of, oh, that would make me anxious to do in front of someone from that community, then maybe we try to reframe it and target an underlying core fear. I really like to bring to mind the addressing framework. And so Dr. Pinciotti and I talk about this a lot, how we can use that framework, which covers all the aspects of sociocultural identities that we hold and reminds us of them. That could be age, race, sexual orientation, gender, ethnicity. Using that framework helps us check in with what themes do fall under this domain. It's not just race and sexual orientation and gender identity. There are at least 9 different themes and identities that can interact. So using that framework to check in and make sure that we're thinking about all the different ways this could come up and be relevant.
I would add too, so Dr. Wadsworth and I are currently working on a follow-up to the call to action paper that is looking at applying a justice-based lens to other types of OCD that implicate identities beyond just sexual orientation and gender identity. We're really excited about that and to share that with everyone. And a large component of that paper involves the clinician kind of educating themselves on what are the historical roots that are underlying this particular presentation of OCD. I joked in the original call to action paper that although, of course, OCD can latch onto anything, it by definition, it latches onto things that are deemed bad or undesirable in society on some level. And so, the joke that like tomorrow I'm going to wake up and have OCD about like, oh no, what if I'm like really rich and everybody loves me and I'm like really attractive, is probably not going to happen with OCD. Right? That might be something else diagnosable. And so, thinking about, even if I don't feel that I personally hold these biases about this group, what have I learned by living in a society that does? What is that stigma that's been internalized that I might not even really be aware of? That might make me have concerns about aging or disability or diagnoses or body size, like these sorts of things that we all just kind of internalize without realizing it. And when we can really understand the historical root of those things, for one thing, we can build a lot more compassion, and this is equally so for the person with lived experience, and just really start to unpack those things and separate a little bit of responsibility of like, am I a bad person for having these thoughts?
I love that there's so much in there, but I love that. And for any therapist or even person with lived experience listening, I think this is great to bring to your therapist or provider and kind of check in around this. And you both kind of touched on something that I think I'd also like to ask about, is the internalized systemic and societal biases, right? And how those processes can actually, impact, I guess, treatment, or also impact, what somebody might do. Can you talk a little bit about that, just so I'd love to kind of get a little more kind of in depth about what those topics kind of mean, how they impact treatment, how they impact a client.
Yeah, do you want to start, Dr. Pinciotti?
Sure. Yeah. So your question is about like how do these kind of historical roots impact like presentation and then kind of approach to treatment?
Yes.
Okay. So with SO and gender themed OCD, the historical roots of like anti-LGBT stigma really is what drives people to have these obsessions about their gender or sexual orientation. Because again, if somebody feels like I don't personally feel like I'm transphobic, I don't personally feel like I'm homophobic, and yet I recognize that there are people in this country who are. And so if I were to hold those identities, there might be consequences to that. And so we can extrapolate that to other things as well. So thinking about, how does systemic racism and white supremacy and capitalism kind of weave its way into these presentations, and make them feel so commonplace that like, yes, of course, we don't want to age, or we don't want to be people who can't be contributing productive members of society because we've been raised in this culture where our value is like inextricably linked to our productivity. And this can play out too in treatment as well. Some people, we say, like, want to perfect their treatment. So, maybe their plan was to do 5 exposures yesterday, and they come in and they say like, good news, Dr. Pinciotti, I did 25 exposures yesterday. And in those cases, I like to say that you're actually sort of like feeding OCD through the back door, right? Like it seems on its surface like, wow, you're doing treatment so well. But we're really sort of like fueling this like perfectionism in OCD. And OCD is one of those, perfectionism is one of those kind of core tenets of white supremacy and capitalism.
Yeah, I think you described that perfectly.
Well, thank you for that. And then one last question, because Dr. Wadsworth, you mentioned there's about at least 9 different subtypes, and I'm sure anybody listening, they'd love to probably hear what are those 9. So can you name those for us?
Sure. Yeah. And if folks want to reference back to this, they could always look up the addressing framework developed by Pamela Hayes. So the original framework covers most of these, and then we've added a few. Covers age/ageism. Diagnosis status, so having a mental health diagnosis in and of itself. With OCD, this might look like a fear of going crazy or being psychotic, or existential OCD. Am I even real or not real? Disability status, so with OCD, that could be a fear of developing a disability that could fundamentally change your life and make it not worth living. Religion, ethnicity and race, sexual orientation, socioeconomic status, indigenous heritage, nation of origin, gender identity, gender expression, and body image and shape and size are the ones that we've added. So anything that you would add to the list, Dr. Pinciotti? Did I cover it all?
You covered that well. I'm impressed at how well you were able to just list that off.
And so just to kind of go over the second half of it, that could be fears of being trans or not knowing your gender identity, not knowing your financial future, having significant financial stress in the future, so on and so forth. So within any of those identities, we'd ask, what is the underlying ism, whether it's ageism or homophobia, and then how could OCD latch on to that and be maybe suggesting that you could be taking on a taboo characteristic or trait or identity.
Yeah, and as I'm listening, I can imagine, because I'm sure, anybody with OCD, they'll also just feeling already kind of bad or shameful around some of the thoughts, right? Because some of them are so intensive, and there are things that people don't want and don't like, right? So, and I know I myself can think of this, but I'd love to have the audience hear from each of you, in terms of if anybody's listening and maybe kind of starts to feel bad, quote unquote, right? About that, not only do I have these, but oh my gosh, maybe I'm also having it in this way that's, not really justice oriented, or, ugh, what do I do? What would you say to somebody?
I would say that the very fact that you're worried about that means that you have a value of justice and caring about others and empathy, right? So if you didn't care that you might be a racist, that would be more concerning, right? And that actually having that fear is a very normative reaction to an unjust society. And so I would encourage people to think about, how is that actually in line with what I'd like about myself or how I'd want to be in the world? And then think about, what am I avoiding that's getting in the way of living life in line with my values? Or what am I doing that's taking up a lot of time and taking energy away from other things that matter to me? So it's probably not going to be, oh, I wish I could be more comfortable saying a racial slur, but I'd like to be able to talk to people more freely and feel more comfortable in social situations.
Yeah, we use that term ego-dystonic for a reason in OCD. It's when the obsession is at odds with somebody's values and beliefs and what matters to them. So if you didn't really care whether or not you were racist, you probably wouldn't develop OCD around that theme, because you wouldn't be obsessing about it. You would just be racist. And so Dr. Wadsworth makes a great point that, the fact that these are things that someone might be concerned about, even though there might be some shame and worry about, like, how are other people gonna respond to this? It means that these are things that are important to you, and characteristics that you don't want to have, that you don't want to be a racist, or you don't want to be homophobic. And hopefully people can connect with providers who understand that and know OCD, and can address those appropriately.
I love this. Thank you both so much. This has been a very invaluable conversation. And of course, as I always like to ask every guest, how can people find you if they would like to find you, Dr. Pinciotti?
So I'm on Twitter, like you said. It's at CM Pinciotti, Pinciotti. I like to share, research findings and things that I'm up to on there. I also have a website, cmpinciotti.com. I do have some handouts and worksheets and resources that I've put on there that people are free to use, including some that are specifically about justice-based treatment.
And I can be found at laurenwadsworth.com. And just want to put in a plug that the paper that sparked a lot of this is on Dr. Pinciotti's website. You can find a reference to it, and you will be able to find the new paper that has a table outlining how to do this with other types of OCD and identity as well on her website, hopefully in the next few months.
Yes, yeah, TBD. Lots of great things that Dr. Wadsworth and I are pairing up on. So the future feels very bright for OCD treatment.
I love it. Thank you both so much for coming on the show.
Thank you for having us.